So we are live.
Good evening to everyone. I am Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in the 43rd session of No Thrombosis. So it is our 43rd session and we are working very vigorously on these topics and we found it is very interesting. Interestingly, today is a World Heart Day on as we are aware that World Heart Day is celebrated on 29th of September to raise the awareness about the rising concerns of heart health and cardiovascular disease and ways to prevent the same. As we also know, this year's theme is Use Heart for Every Heart as per the World Heart Federation, which means that use heart to think differently, make right decision, to act courage, and to help others. And the heart is the only organ which can hear or feel, and it is the first and last sign of life, and that's very important. And for every heart which involves use of for and swing of focus from actions themselves to the beneficiaries of the actions, allowing a wider applications of the campaign while we are making it more personal. And all objective is to help and achieve cardiovascular health for every heart. And with this occasion, we will be having, in addition to our regular case presentation, our course moderator, Dr. D. Prabhakar sir, and our course director, Dr. M.S. Hiremat sir, would be presenting a unique case for this occasion. And it gives me, can we move to the next slide? It gives me a pride, privilege, and honor to welcome and introduce our course director, Dr. M.S. Hiremat sir. As I mentioned, it's a 43rd edition, and we used to conduct every fortnightly. Now we are conducting every monthly. And since 2020, sir is continuously participating in this program as a course director. And we always feel that sir's interest is making this program a successful. We all know sir is a director at Ruby Hall Clinic Cath Lab, and he is a former president of CSI in 2017. He is a convener of a National International Council of India of CSI from 2004 to 2006. Sir had proctored many interventional cardiologists and has given talk and live courses across the globe. Though he is a coronary interventionist at heart, he is equally adept at peripheral arteries involving leg, carotid, and aorta. He has participated in many groundbreaking trials as well. Sir would be joining in 2 minutes. Now I would like to welcome our course moderator, Dr. Girish Navasundi sir. Sir is a director of Cath Lab and senior interventional cardiologist at Apollo Hospital, Bangalore. Sir has performed more than 4,000 angiograms through femoral, radial, and ulnar approach, and more than 1,600 angioplasties, both coronary and peripheral. Sir has been a first cardiologist to implant as a stent in a private healthcare sector in state of Karnataka, and first cardiologist to implant MRI compatible AICD system in a state of Karnataka, and also a first cardiologist to implant temporary coronary stent in the state of Karnataka. And additionally, sir has been always a guide and friend to us at Emcure. Thank you very much, sir, being a part of this program as a course moderator. Now, I will take a privilege to welcome and introduce our course moderator, Dr. D. Prabhakar, sir. Sir is a consultant and interventional cardiologist associated with Apollo First Med Hospital and Ashwin Clinic, Chennai. Sir is now a treasurer of CSI 2022 Chennai and quite a busy in upcoming CSI meeting in next few months. Sir has been a faculty at Madras Medical College, Chennai for almost 5 to 6 years, and sir has participated in many national and international conferences as a faculty, and sir published many articles in reputed national and international journal. And as I mentioned, sir is going to present a case along with our course director, Dr. M.S. Hiremat sir, on this occasion of World Heart Day. Can we move to the today's speaker? Now we'll move to the today's speaker and case presented. Dr. Swapnil Gurde from Bhopal, a senior consultant cardiologist at Smart City Hospital, and also worked as a consultant in Department of Cardiology at Siddhant Red Cross Super Specialty Hospital, Bhopal, and many papers on his credit. So Dr. Swapnil Gurde is going to present LAD CTO angioplasty in young female. Now let's move to our second case presenter, Dr. Samir Kuba. Sir is a director of clinical and interventional cardiology at Max Hospital, Vaishali. More than 20 articles on his credit, and participated in many national and international conferences as a faculty, and has been an author for more than 4 book chapters. And Dr. Samir would be presenting challenging calcified coronary case during the primary angioplasty. And I could remember this is the second time with all our faculty or all our case presenters are presenting their interesting cases tonight. Let's move ahead with today's program. So with this, I will stop here, and maybe I will just give this a forum to our course director for opening remarks. Followed with that, we can have our first case by Dr. Swapnil Gurde. Over to you, sir.
Thank you, Dr. Swami.
I think sir is on mute. Dr. Hiremat, sir, can you? We are not able to hear. Okay.
Sir, you have to unmute yourself. You're muted.
Yes.
Okay. Can you hear me now?
Yes.
Yeah. Sorry, I was in another meeting, and that's why I'm joining a bit late. But let's start with the first case.
Dr. Swapnil, you can start with your case.
Right. So, is my slide visible to everyone?
Yes. Can you go full screen?
Yes, sir. Is it okay now, sir?
Yes.
Very good evening to all the esteemed faculty. Today, I am going to present a LED CTO PCI in a young diabetic female. So these are the details about the case. She is a 28-year-old female and recently married, and she was diagnosed as a case of diabetes since 5 years back, and it was type 2 diabetes mellitus. She had angina on exertion, which was of class 3 NYHA on presentation, and on echo there was a mild hypokinesia of the LAD territory with mild LV dysfunction. EF was around 40%. The ECG was suggestive of old enteroseptal valve myocardial infarction, but on taking history as such, there was no event which we could conclude that okay, this might be the index event of MI. So this could be the case of silent myocardial infarction. Her majority of the biochemistry parameters were within normal limits, other than HbA1c, which was 12.8. She was on oral anti-hyperglycemic agents, and her LDL and triglycerides were raised. So this is the angiogram of the patient, which shows that is the video visible to everyone?
Yes,
sir, yes, it's visible, sir. Yeah.
Correct. So I'll start with the one. It shows a complete occlusion of LAD with the weak appearance of the proximal segment of LAD, and before that a major diagonal was arising. The LCX is also subtotally occluded, or we can say there is a bridging collateral in the proximal segment which is filling the distal segment. So she was having 2 CTO lesions. The RCA showed a distal lesion at the crux, just before the crux, and that was leading to the majority of the collaterals which were filling the LAD retrogradely. Can I shift the slide? This one?
I think you should play each slide, otherwise it's not very clear.
Okay, sir. So I'll play each slide. So is it okay now? I'll play it sequentially.
No, can each slide be bigger instead of having 6 of them together? Can you just get once? Or difficult?
I think he's already fixed it on the PPT. Sir, you go ahead one by one. I think we'll try to figure out. Go ahead.
Okay. So she was diagnosed to have a triple vessel disease, and both options of bypass as well as PCI was given. And the patient opted for PCI. We calculated the JCTO score. It was one, probably the length was the only factor which was going against us. And she was of a government, she was entitled for a government scheme. And so we were a bit short of using hardwares with Liberty. So we planned the procedure next day with a femoral route, and dual injection was not taken, as we could see the distal LED filling through either through the RCA or through L6 collaterals also. So we plan to take a micro catheter and to start with pilot 50 and upgrade the wires as needed. We took extra backup 3.56F and hooked the left coronary ostium. We started with the pilot 50. In this view, it was looking promising that we might reach the lesion, but eleocranial view showed that the wire was going either into some branch or it was outside the true lumen or the tract. So we took the micro catheter to stabilize the wire, and probably we were not able to negotiate pilot 50 through the true channel. It was again and again going to a false channel or some smaller branch. After a few minutes, we realized that there was some slight proximal LED dissection, which was non-flow limiting. So we continued, we checked it in other views and it was not catastrophically bad. So we tried to upgrade the wire to Sion black along with the Caravel micro catheter. But this time the wire did not go into that small branch, which pilot 50 was entering every time. This time we were into the LED, but probably it was subintimal, as we can see in this angio. I will pause it for a second just to see that this was the probably true lumen, and the wire was continuously going into the adventitia or subintimal space. We tried to check it into multiple views. After some time, after some resistance, it went into probably a true lumen LED. And I think it was a true false true tracking of the wire, which in a lighter vein we can call a poor man's limited integrate subintimal tracking technique. Although we did not use a second wire, so this is not a true representation of the last technique. After which the wire floated easily into the LED, and the proximal dissection did not progress. So we confirmed the wire into multiple views, and once we were sure that it is into the true lumen, the wire was floated smoothly. And after that the procedure went routinely. We pushed the micro catheter and exchanged the Sion black wire with the workhorse Sion blue wire, followed by it was a routine angioplasty. It was pre-dilated subsequently with 1.5 to 212 and 2.25 balloons. So after that the filling was better, and we were more confident to go ahead with the procedure. We took multiple shoots, and the lesion length was probably around 20 millimeters. That was the only problem with this CTO. Otherwise, this was quite a usual case. And we took a 2.5 into 36 drug-eluting stent and inflated it to the nominal pressures. But while inflating, we realized that in the mid segment, probably where it was a tight CTO lesion, or it could have been the possibility that wire went subintimally, that portion was not inflated properly. In multiple views, we could see that. And we again inflated the stent balloon only to higher atmospheres. And after that, we again checked the angio. And in eleocranial view, there was, sorry, it is stuck, I think. So I'll just start. So in eleocranial view, it was showing that there was some stenosis still left over the mid segment, and we inflated it with a 2.75 short balloon, a non-compliant balloon, to optimize the angiographic result. So this was the final shoot of the LED. So the fluoro time was around 29 minutes and 35 seconds. The dye you used was 210 ml. The follow-up RFT was normal, and the procedure time was around 45 to 50 minutes. We have further planned this patient to undergo PCI to RC and LCX so that we can completely revascularize it. So in recap, this was a 28-year-old diabetic female with a triple vessel disease and 2 CTOs. We upgraded the wire from Pilot 50 to Xeon Black with the help of a Caravel microcatheter. The limitation of this presentation is that we did not confirm anything with the coronary imaging, which we should have done because of the lack of imaging system in my lab. But probably the wire went subintimally to the true lumen, and followed by sequential dilatation was done, and optimum angiographic result was obtained with a drug-eluting stent. Just a single slide and few words about the mini-star and last techniques. In mini-star technique, ideally it says that we should be taking fielder FC or fielder XT wire. 2 curves are placed on the wire, one smaller curve and the second curve around 3 to 5 millimeter proximal to the tip. And the wires are advanced for the subintimal penetration of the CTO, and the efforts are made to re-enter the true lumen as proximally as possible. Star technique. In the last technique, instead of giving the curves to the wires, fielder FC and fielder XT wire are entered to the just proximal to the or at the point of the CTO lesion in subintimally, and then it is exchanged with the help of a microcatheter with a higher tip load wires like Confianza Pro 12 and Pilot 200, so that it enters the true lumen. So these were the small revisions of the mini-star and last techniques. Although there are no long-term published data on the short and long-term outcomes of this technique, there was only a single study by Lombardi and et al., which was published in 2009, and it only technically described the procedure rather than giving any long-term or short-term data. So that is the presentation from my side. Thank you very much for patiently.
Dr. Swapnil, a couple of issues. You used 6 French.
Yes, sir.
I mean, most of the time for CTO,
7
you
French.
do not know what kind of hardware you would need to take through the guide. So I have switched to using 7 French, unless you have issues like very small body frame, creatinine is up, and so on.
Right.
Those cases, maybe I would use 6 French, but otherwise, most of the time CTO is with a bigger diameter catheter. You would never know what you need at what stage. Also, your patient had LDL of 131,
Yes,
which is clearly very, very high. I think we should target at remove the 1 and it should be 31,
yes,
something
sir.
like that. Otherwise, she would come back again with something else.
Yes, sir.
So I think you should consider something like injection Repatha along with whatever you used. So this patient is only on statin, or you're using ezetimibe?
No, sir. Right now, she's only on statin. She has presented to us a few days back only, probably 14, 15 days back. And I have requested her to come back and follow up. I'll check whether she responds to the statin therapy or not. So that is the plan for now, sir. She's right now only on statin, honestly.
I would probably feel that with 131, what dose of rosuvastatin you're using?
40 I have given, sir.
Dr. Prabhakar, what do you think? You would use ezetimibe?
Milligrams of rosuvastatin in such patient with so much of diffuse disease will bring down your LDL by 50%, which should be around 70, 75. Based on Indian patients, lipidization India criteria, you'll have to come down to 50, and you will definitely need an ezetimibe in these patients. So this way you can start with ezetimibe, because ezetimibe is fairly well tolerated.
Yes.
And 40 rosuvastatin, unless the weight is very less, I generally start using 40 rosuvastatin under 10 milligram of ezetimibe. Another thing is, within 2 weeks, you can check the lipid profile and see whether you're reaching target, because 80% of the effect is available within 2 weeks. In case you want to wait, 1 month will give you the 100% effect. So recommendation is either 2 weeks or 1 month. Both ways you can do it. You will still get your lipid profile. and target 50 with so much of disease, I will try to get lower the better. If it goes down to 30, I'll be very happy.
Yes, sir.
You're planning a second sitting also.
Yes, sir.
Regarding the case as such, I think you adapted to where it went and thought it was subintimal and got a re-entry and good results. And unless you're going to have an imaging, I think like what you described yourself, I think you're not going to get the right answers. But I think the end result looks good. You should do well. And you're planning a second sitting. So when you do the second sitting, you'll definitely do a check shot of this. And that time you will know how the results are and how the patient is going to handle.
Yes.
I think well handled.
Thank you.
Yeah, I think not much to add, but as Sir said, couple of things are important. A CTO requires good planning. You need to, look at the distal vessel. Is there any disease beyond that? Where are the collateral, homocollaterals, or it's coming from the other side, contralateral collaterals? Then what is the probability of damaging if you go too long subintimally? Are there any big branches, such as large diagonal, large septals? When you're especially in the proximal to mid segment of an LAD, if you have a CTO and if you track too long subintimally, you may shut down many of the major vessels, such as large septals and diagonals.
Yes.
And always start with a 7 French guide,
Right.
because you never know. You may have to leave one wire in the branch, take the second wire, take a microcatheter. So make it a habit to always use a 7 French, and wire, upgrading in terms of, that was well calculated, and try to keep your distal re-entry to the shortest distance possible. That's when the stents patency rates will be maximum.
Yes.
Even if you re-enter the true lumen, but if the course is long, the chance of stent failure is much higher. But I really congratulate you, young age, and you've chosen and delivered a good result.
Thank you, sir.
I mean, this true, false, true is done on intention, or it just happens?
No, sir, it just happened, sir.
Just happened.
Yes, sir.
No, I thought the way Dr. Girish was talking, I thought he does it on purpose, true, false, true.
No, sir, I did not did it on person. It just happened. I noticed it later on that it has happened.
So, but sometime, when you have very calcified lesions or very angulated lesions, by choice, we go a short distance subintimally and then re-enter. We know that this is going to be subintimal re-entry technique. We try to keep it to the minimum possible during those and stay away from the large branches.
Yes, definitely.
I would feel very difficult to judge where you are entering into the subintimal space and where you are coming out. Many times you have no help from contrast, and you would probably base your decision based on side branches which are seen before we actually get into balloon and wire.
Very true, sir. Very true.
I have a small question. So he had a small dissection there, and how does it change the way we approach these cases? Do you have to be a little more cautious?
So, that you will always go through lumen from the proximal to the distal. There are going to be areas of, dissections.
Sir, due to some net issues, I did not catch you, sir. Can you please explain
No,
it?
even I did not hear what you said, Dr.
I'm sorry.
I've rejoined, sir, in some other network. I'm changing my network.
No, he asked us, is there a strategy difference if there is a dissection in your proximal segment or a mid segment? I think once you start a CTO, only 50% of the time that you may be truly inside the lumen all the time. But another 50% of the time, you will always be subintimal for certain distance and you'll be coming in. So you need to keep that distance to the minimum possible. The 40 years old, newly diabetic, I don't expect a subintimal because there's not too much of calcium, there's not too much of tortuosity, there's not too much of fibrotic tissue, or it's not even a long-standing CTO. But if you're doing a CTO in a 70-year-old post-bypass, they're not going to be, truly true lumen to true lumen exits. So you need to have the strategies. I think whatever you are, star, reverse star, all that will be applicable there, because they're not going to be straightforward and you expect dissections.
Good.
All right, should we move to the next case?
So, Dr. Samir, I request you to please share your case.
Can you see my slides, please?
Yes, sir.
Yeah, thank you so much. This is a 62-year-old male who presented to us with an NTRMI late evening, and he was referred from another hospital. Fairly stable hemodynamics, so we took him for an angiogram, and this was the angiogram, which actually showed a very long segment of LAD disease starting from the proximal part. It was a very angulated and calcified LAD. The RC was pretty okay. There was a TIMI3 flow in the LAD to begin with, and at one point of time, seeing this kind of an anatomy and being as a solo operator at that point of time at a late evening, I thought that probably CABG is going to be a better option, because I anticipated some difficulties, and there were certain limitations in the form of unavailability of rota in my lab, and again an acute scenario. So I discussed with the relatives about the TIMI3 flow and need for the CABG, but they were just not willing, and they said they have brought him for an angioplasty. STs were elevated, chest pain was ongoing, but I still felt that probably I may have challenges, so let me give them this option. But nevertheless, I started off, and this was a 2.5 millimeter non-compliant balloon. As you can see, the waist is not broken in the most critical part of the lesion. Nevertheless, the balloon went in fairly okay. But I still thought that let me prepare the bed well, and kept on giving dilatation with this balloon. And then the Synergy 2.528 was the stent which I decided to use, but it doesn't negotiate. And so I thought, let me further dilate at higher pressures. Obviously, we used a buddy wire and all those things, but probably the lesion, I believe, with the grittiness it had, probably would not give way. Maybe it was a calcific nodule or a thick sheet of calcium. Anyhow, further dilatation was done, and I thought that probably now I should be able to actually negotiate my stent.
What balloon are you using now?
So now then, this was an OPN NC 2.5, which actually was tried. Obviously, I thought that the waist had broken and things had become better, and now I will be able to negotiate. But again, there were challenges. Buddy wire was again tried, and the lesion did break, but the Synergy would not go. So I then thought, let me use a smaller stent, and actually I had to use a guide extension catheter also to deliver this small stent. I don't have images of that, but finally Promos 2.2520 I could negotiate somehow, and that was deployed in the distal part of the lesion.
Dr. Samir, can you explain why 225 went and 2.5 could not go? I mean, you're talking basically a deflated profile, all right? I mean, 225 and 2.5, according to me, probably have same deflated profile and should be able to go through. I mean, 225 can go, 2.5 also could have gone. Probably you prepared the bed better when you took the 225 stent. When you were taken 2.5
So
stent.
I actually tried the synergy again after preparing the bed better. It was a longer stent. It was a 28 millimeter stent. And because I had opened it, so I thought, let me try it again. So, but despite my multiple efforts and even trying to use a guide extension, that stent would not go. And so finally, really changing the stent to a Promus, I don't know, did that work, or maybe a smaller length, 20 millimeter and a 2.25. But that actually somehow gave way, and I was able to negotiate that, sir. And then on coming back, I took the same balloon and tried to inflate the proximal part of the Promus stent here, because the way the lesion was behaving and the feel of angioplasty I was having, and even with the guide extension, I was having some issues. I thought that let me open up the proximal part of the stent skirt so as to negotiate the synergy now, because it required anyhow a longer stent for the proximal lesion. And this is again the proximal stent part of the stent was dilated at high pressures with the stent balloon, and then Guidezilla was again used to negotiate 2.5 28 synergy, and this time with the guide support I was able to negotiate this stent, and that was overlapped with the previous stent. But in the whole process and in the whole procedure, probably there was a dissection that happened in the ostial part of the LAD. And after deploying this stent, there was a haziness in the osteoproximal part of the LAD, which was visible in this left panel. If you see that there was a dissection, probably that happened. And that was covered with another 312 Zynes stent at that point of time. And that was finally deployed. And obviously post dilatations were done. A 3.5 was used in the proximal part to optimize the result. In the interest of time, I'm not showing that. And this was the final result, which actually I was able to achieve. So I initially had thought that probably I would require 2 stents because the lesion was long, but I ended up using 3 stents, and a lot of problems in this artery, which actually was a TME3 flow artery to begin with. And that is the final result. I did not have imaging at that point of time, but we do call and do imaging frequently in our labs. It's not available around the clock. And I mean, the patient has been doing well, and I just went to literature about imaging, and that actually shows that calcified nodule can be responsible about 2 to 7% of sudden cardiac death in ACS patients, and on-site rotablation at times is not available, and it may be a challenge in ACS STEMI situations. Obviously, buddy wire, anchor balloon, OPNNC, guide extension, shorter stents are some of the strategies, and we tried all of them over here, and one must be well versed with these technologies, with these techniques. But this is a small paper on calcified plaques in ACS, wherein they actually have divided these calcific lesions into superficial calcific sheet, eruptive calcified nodules, and calcified protrusion. And they actually are 3 different types of calcified plaques, which are actually now very well recognized on imaging, and they have some clinical implications. And probably in my case, probably it was a calcified nodule, and this is how they look on imaging. The calcified nodule is very irregular, and it just bulges into the lumen. Superficial calcific sheet is actually around the lesion hole, and calcific protrusion is relatively smoother. And most common in the situations is a sheet calcium in this study, about 68% of the cases, eruptive calcified nodule around 25%, and calcified protrusion is in 7%. And we are seeing elderly people, patients with CKD, and at times they come to the lab at odd hours, and we see these kind of scenarios relatively more frequently now. And what they have mentioned in this study is that the eruptive calcified nodule actually has the highest calcium burden. And red thrombus is predominant in eruptive calcified nodule group and white thrombus in the superficial calcific sheet. And post-PCI myocardial damage is greatest in the superficial calcific sheet group, and high post-PCI CK values were also noted. And if you look at the location, eruptive calcified nodules are most frequently located in the RCA, whereas superficial calcific sheet in the LAD. And probably this is because of the dynamics of the RCA, where there's a hinge-like movement at the AV groove where the RCA passes, and that is the reason they say, which probably on imaging now they have seen. And these strategies of treatment may also be different. The presence of a smaller lumen area in the superficial calcium suggests that debulking or plaque modification, such as VOTA, is actually having more of a role in such lesions. But in contrast, if you have eruptive calcified nodule, you may require a fracture-resistant stent with constant hinge movement. And calcified protrusion group, which is the smoother sort of protrusion into the lumen, not like the eruptive calcified nodule, they may result in stent malapposition and may have some long-term stent failure issues. So thank you very much. And the house is open, sir, for discussion and your expert comments, sir.
I think good case handled well, but I think unless you have an imaging, what all the descriptions that you have mentioned about calcium, unless you do an imaging, you're not going to get an answer. I think you showed the pictures of OCT and then you describe it. The calcified nodules can be a big problem. So in a case where you expect so much of calcium and a problem, you actually have to be looking at a planned PCA wherein you have all the backup. That would have been much easier for you probably in this particular case. So, but otherwise, what was the guide extension you used, Guidezilla?
I only had Guidezilla, sir. I have talked to people, and some say that a new catheter in the form of a Guide Plus is very, very good, and that is very much more negotiable than a Guide.
That's actually my case. That's actually my case. When I'll show you how the Guide Plus helps you in this. If you had a Guide Plus, you would have got away with this. I will show you how a Guide Plus helped me. That's my next case. That was my next question. But I think the OPN balloon, once you had used it, it always helps. And did you have difficulty getting the OPN out? Because once the OPN is inflated, sometimes it snugs, kicks to the wire. Difficult. And then was the OPN deployed? Was it delivered directly, or was it through the Guidezilla?
So I was able to take the OPN, sir, directly, and it went in smoothly. There was only one wire, and I was not using a hydrophilic wire, which we should not use with an OPN. And it was a fair expansion, and I could see that kind of an expansion. And I thought now the stent would go, but still it did not go. So probably it was a combination of calcium and tortuosity. Then I used a guide extension to deliver the stent, the synergy stent. That also I failed. And then finally it was a smaller stent, Promus 2.25. Somehow I was able to negotiate. Now my problems were, I was the solo operator. It was an awkward time. The staff was limited. And I actually, in the heart of hearts, I didn't want to do this procedure. I thought it's a TIMI 3-flow. Let me subject the patient to a CABG or plan it probably next day with all those things. But the family was just after my life. We have brought him for an angioplasty. He's having chest pain. Do it. So I know that a TIMI 3-flow, and I could have.
How far were you able to milk the Guidezilla?
So I was able to take up to probably the mid part where, as you see, that diagonal. Which was flowing initially, but then had I could. In fact, I used the inchworm technique and probably the balloon, because the balloon was going easily. The stent was not going. So I was able to take the balloon relatively distally, but despite that, the Guidezilla did not go. And I thought that it should have gone. But again, as you are saying, sir, I talked to people and they said, Guide Plus and things like that, maybe a change of the guide extension catheter would have helped, or maybe there was a diffuse calcium which was there, and something which we didn't allow. But thankfully the Promus went, and even after the Promus went, I dilated the stent, and then I took the balloon back and dilated the proximal part of the Promus stent, and now hope that synergy would go directly, but again it would not go, and with the help of guide extension it did.
Dr. Samir, I just had a couple of comments. I think I really appreciate your understanding of calcified lesions. I think you're very, very clear about it. But when you find something like this, you need to have a plan B, plan C ready. Once you think, okay, I see a long sheet of calcium on a plain cine, It could be superficial, it could be a plate, we do not know. Next, there are two strategies because you set a time for each of the strategies. If it doesn't work, I'm going to move on to the next strategy. If you got a great result, but if it was me in your place, probably what I would have done up front, I would have used high pressure balloons to dilate the lesion very, very well, and use an inchworm guide liner if it can, guide extension if it can go. If it cannot go, then straight away, once you dilate and your dilated balloons are able to cross the lesions easily, NC balloons which are already rewrapped, if they're able to cross, I would switch over to two short stents right up if the first long stent does not go, because the compliance of the vessel means ability of the vessels to bend and accommodate this straight rod, the unexpanded stent, is going to be a challenge if you use a 38-48. The third, I think, using a cutting balloon in these circumstances helps you to really reduce the constricting power of the vessel. Whatever you expand, it recoils. It's a not purely calcified, not purely fibrotic. These are usually fibrocalcific lesions. So if you use a cutting balloon, it makes the vessel cut in multiple planes, that half of it is become already dilated and it cannot recoil back. And thirdly, you're very lucky that your stent did not go into a segment where you cannot dilate the stent after you have implanted the stent. So don't ever be in a rush to take the stent down. Make sure your balloon is fully expanded. You can see fully expanded balloon. Then only try and take a stent. And lastly, I thought, there are going to be issue with simple guide support. Even a guide liner is not going to help you. In those times, take out the guide liner or guide extension, put another wire into circumflex or OM, just anchor the guide very, very well. And same this 48 stent or 38 stent will just slip in. It just needs little nudge or, slip away from one point where it is touching. And lastly, Dr. Hiremet sir asked you a question, why did the long stent not go? One is length. Second, many a times when you push the first stent and come back, there are micro damages that happen where they're not as smooth as possible to take second time down the same lesion. Thank you.
So I appreciate all those points, sir, and thank you. So first and foremost, the initial balloon which I took was a 2.5 millimeter NC balloon, non-compliant balloon, and it was inflated to around 16 to 18 atmospheres. And so I thought that it was a fair dilatation, although in the first go, there was some waste which was already there. And the initial stent synergy which I took was a 28 millimeter. So it was not 38 or longer than that. So it was a 28 because I anticipated that a long stent anyhow is going to cause a problem.
Right.
But it didn't go. And cutting balloons are very good thought and strategy came to my mind. But by the time all these things had happened, there was some dissection which had already happened. I had used an OPN, and that OPN NC also which I used was with a lot of, I would say, calculated pressure, 2.5. I wanted 2.25 also, which is not available, slightly undersized the open NC and go slowly. So it was 2.5, very slowly up to 28 I went. And then when I saw the...
I think you did a fabulous job. What I'm saying, if you're given the same case again, maybe this coming week or a month from now,
or tomorrow,
we always debate about what different would you do, just that. But you did a fabulous job.
No, sir. Actually, I am just trying to say what my situation was in that scenario. So your comments, they are so welcome. I've learned so much from you virtually in the forum. So I'm just telling my thought, which was going at that point of time.
I don't envy your time. I know it's difficult being solo operator in those times. But I think, having in your mind plan A, B, C, and set a timeline, I think that lets you have the options coming in quickly. I think the best strategy was 2 short stents. I think that was the savior.
Yeah, I started with a 28, did not go 2.75 28, so 2.5 28 rather. And then I took a Promus 2.25 20, which was luckily available, and it went. And again, after that, also to negotiate 2.5 28 synergy again was an issue. So cutting balloon, I was slightly afraid that after the dissection had been made, and I know I was slightly afraid of using the cutting balloon at that point of time. Fortunately, I was lucky, I would say. God was there and things went on fine. Retrospect, I think, and relatively, I was working with a cool mindset and I was taking things down the line, looking at the lesion and not in a hurry, because to begin with, it was a timid three flow artery and I could have worsened it actually. So that was something which was in my mind that was going on. And had I been with a operator with me who was supporting me, things would have been very different. And had it been a better time of the day. Sometimes you don't want to handle these acute lesions, which are TME3, but you have to handle them by the pressure of the relatives, which at times is difficult. So those are some challenges which I faced, and I thought that I'll bring this to the fore to get the opinion from experts like you, sir.
Girish, sir.
All right. Should we go on to my presentation?
Sir, I'll finish mine because it's more or less similar to what Samir did. The only thing is the guide plus was my savior there. So I thought it'll be similar to his case. We can have a similar discussion.
Okay, go ahead.
I finish. I thought because he said that, I thought it might be useful if I finish that presentation immediately. It'll what is that? Yeah, basically this patient is a 72-year-old dyslipidemic hypothyroid male. Chest pain one day, NSTEMI drop was elevated. ECG only showed an LVH strain. Echo no wall motion abnormality, but there's probably a slight uptake of the ST in the inferior leads. So a patient came in the night and family was plus minus. Next day morning, I spoke to them and took them up for an angiogram. And not much on the LAD side. There is a lesion in the OM and heavily calcified vessels. Clearly, nothing much to do on this. Once I started the RCA, there was a very tight proximal RCA and also a distal RCA, but not much of good segment anywhere. So if I have to do it, I thought this was the culprit looking vessel. Calcified vessels, as you can see, and if you can see that there is a lot of calcification. But true lumen, I think we can definitely get away with this. So what I did, I used a run-through wire. My guide support wasn't the best, so I used a second BMW wire, parked both wires inside, because I didn't want to lose access once I start dilating. So I used a 2.5 mm NC balloon, went to the maximum pressure, went dilated all the way. And this is how it was looking initially. So then I took went ahead again. Actually, once I saw the lesion on the left side, I went ahead again, dilated again fully, and ambitiously, against what Dr. Girish suggested for the previous case, I thought, let me take only 2 stents. So to cut the cost of the patients, I took a 2.75 into 48 Zions. And interestingly, it just went straight in. I never had a problem. So straight went inside. And I was so excited by the whole thing. I just positioned it at the ostium and dilated it. Now, if you look at it, what I'm doing here is I'm jailing the BMW wire inside. And it's not an N wire, it's an Oxford wire, BMW. The moment I did that, I realized, after I dilated, I realized that there is a wire inside. I said, okay, let me try to get out that wire. And this is what I did. So I looked at the thing, brought the wire close. Before I realized what was that, I thought, let me give a small dilatation proximally before removing the wire. And that was my biggest mistake. What I did, then I tried to pull out the wire. And when I tried pulling out the wire, I had a little bit of difficulty. And still I managed to get the wire out, and I looked at it. The check shot looked pretty good. The whole thing looks good. This distal stent looks good. Everything looks good. Then I had a little bit of difficulty negotiating the BMW. I wanted support for the second stent. So I removed it and went inside the lumen, and I wanted some more support and went in. Now, once this happened, I tried to get the second stent inside. Nothing would go. Then I brought back the original 2.5 mm balloon that wouldn't cross the proximal portion of the wire. I'm in the run-through wire, which is my original workhorse wire. Then I did a stent boost and saw that it was not even reaching the stent. Now, if you see very carefully, I missed something here. Then what happened? I went ahead and started looking at it very carefully again. We went back to the stent boost and saw, you see what happens here. The proximal portion of the stent seems to be totally distorted. It's mangled stent. So when I pulled the original wire of the BMW wire, something has gone ahead and hit the stent. So the proximal portion of the stent, yeah.
The guide probably went and hit the stent.
Exactly, sir. In fact, I had a little difficulty pulling it. And I was thinking about getting a 1.1 balloon or a small balloon inside, but it started moving and coming out. I didn't record it because I didn't expect a problem. Then once it came outside, once I started getting inside, I couldn't get inside. So then I thought, okay, this is going to be difficult. The next step I did was I thought I'll get a guidezilla. Now you can see the distal marker in the guidezilla. It was milked down up to this level. And once I came to this level, I could not go beyond that. I could not enter the stent. So I changed from an N 2.5 to a 1.1, then tried at 0.9, nothing would go inside. I could not get a good support. Ultimately, actually, the Guidezilla was coming back. And I did another stent boost, and till that point, I was actually a little doubtful about the stent being mangled. And once I took this view, this is when I clearly saw that the proximal portion of the stent is totally mangled. Now, the most important thing was keep the original run-through wire in place. Then what I did, I changed the Guidezilla to what Samir was alluding to, the Guide Plus 2. Now look at the Guide Plus 2 going inside here. I'll play it again. See, it's here. You don't need a balloon support. It just glides inside. The tip is very soft. And after that, there's nothing much to do. I just have to do it, post-dilate it, and did a little, kept it to the ostium and came out with this. Now, this is how the final result, both the stents opened. And since I had the original wire access perfectly there, I did not have a problem. Now, there was a comparison. There is a very small comparative study between the Guide Plus and the Guideliner. There's not much, but what they noticed was the smaller profile balloon crossing in a C2 or a 99% stenosis, more or less similar to this. In this, it's an acquired 99% stenosis. The Guide Plus seems to be faring much better. So this is actually, I never knew Samir was presenting this case, but it just so happens that this is how the Guide Plus helps you in a difficult situation. It just happened last week. So I thought I'll just give you an extra answer to that. It just corresponds to what Samir had said. Sir, your comments?
Well, I'm speechless. You used a lot of tricks which actually didn't even occur to me, but you use them and use them effectively, and that's why we have a very nice end result. So it was done in 2 phases. One was previous day and one was the next day.
No. Everything was the same phase. The angiogram, and it was an ad hoc angioplasty. Simultaneous. Everything was done in one sitting together. Because the wire was there in place, I couldn't get out the wire, because once I realized the stent was mangled, I had to do the whole thing at that point. I can't remove the wire. Then I lose the original lumen, because the first stent was delivered through that. I didn't want to destroy the stent, or I didn't want to plaster the stent in any abnormal way. And I still managed to get it, because obviously only the Guide Plus 2 helped me. It's a beautiful stent. So actually, I've used it about a couple of 2 or 3 times. And the reason for using, you will probably ask me, why did I use the Guidezilla in the first place? The Guidezilla was Ox. I thought I'll cut down on cost. But ultimately, the Guide Plus worked.
One small comment I would like to make here, sir. When you were using the Ox Guidezilla, what was the guide catheter? You were working with a 7F guide or a 6F?
No, it was an ad hoc plasty routine one. I didn't expect too much of a problem. I just went on with a 6 French.
So, but does an Ox Guidezilla go into a 6F guide?
It does go well.
Because I've had issues, and in fact, I tried it off on with my cath technician on off table, because once we were doing it with a 6F guide catheter, and the Guidezilla O did not go. And when we looked at it and we put it back on the table, ex-patient, we could see that the Oxford Guidezilla doesn't go in a 6F guiding catheter. And then we talked to a few people.
Probably only the second use. I don't know how many times. It did go inside. I did not have a problem with that.
Okay, sir. Because this is something which I talked to a couple of people, and they said, ideally don't use Ox, and if you're using Ox, then use a 7F guide catheter. Yeah, because 6F Ox Guidezilla doesn't go. Thank you, sir.
Sir, Hiramat sir, you were saying something.
Oh, I thought you got into trouble, but came out very well. Congratulations. Any comments, or we move?
No, sir, it was just very complimentary to what Samir said. That's why I said I'll go ahead immediately with that.
No, very good. I think similar problems dealt differently.
Just the availability, sir. Apollo Hospital's shelf is huge, so you get everything there. That's a big advantage. Girish sir, anything?
Should we go to my case now?
So just to announce, Dr. Girish sir had to move to an emergency cath, so he has left the meeting, sir.
Fine. Sir, you go ahead, sir.
Yeah. Manish, can you get my slide on? I think he's gone to sleep. Just give me a second.
So the other thing about till he comes in, I probably should have, when you use a long stent just for stability, I think we should remove the second supporting wire, the buddy wire. That's one more thing I wanted to stress in that. So that's what I realized. So if you
But
want,
sir, sometimes that buddy wire actually helps you to negotiate the long stent.
once you have negotiated the stent and gone inside, I think I could have probably removed. No, the reason why I tried pulling it out was I thought this is a 48 millimeter stent. I'm going to stent from the ostium. The chance of it getting trapped is going to be very high. I didn't want to take a chance. That's why I removed it. I never realized that. In fact, Dr. Hiramat sir would remember that previously we were discussing you can keep a wire in the side branch. That kind of hit me there when I was doing the case. This is exactly what struck me. But when I put a 48 millimeter stent inside, I think the chance of the wire staying put inside is going to be very high, very high. So probably once you put the stent inside, just before you deploy it, probably you can remove it. I think.
Yeah, and probably an Oxford BMW in a calcified lesion may actually compound problems. So
exactly, there's small lessons you have to learn. But luckily you got away with that. Sirish sir, your slides came and it went off. I think he's also off.
Sirish sir got disconnected, sir.
Anything you want to say, Swapnil, about the case?
Sir, I wanted to ask Sameer sir, do you think there is any difference in the trackability of Promus versus Synergy? Because in many times I have experienced in, although I do have a small experience, but Endeavor sometimes go better in terms of trackability as compared to Onyx. This is what I have also felt.
So I have not used much of Endeavor. It is not available in my lab, but there is one stent which I use in most of my cases where trackability is an issue, and that is Ultimaster from Terumo. And that has a very good trackability, has bailed me in certain scenarios, but Ultimaster again was not available at that time. And so you have limitations. I probably believe that sometimes when you try to negotiate one stent initially, it doesn't go as Dr. Girish was mentioning, something happens on the surface of that stent also. And then it may not go. And luckily, I undersized to a Promus 2.25 20, undersized and under length also. And it went. So that is the usual strategy. You try a smaller length of the stent to go. I don't know exactly. Synergy is a good stent.
There is no difference.
Yeah.
Okay. But as such, there is no theoretical difference between the design of the Promus versus Synergy, because they are both from the Boston, I think.
Both from Boston, and probably the trackability they say for Synergy is slightly better.
Synergy is better, and the other stent that is now available is the Science Alpine. The Alpine, what I have done, I've actually done the bench testing when it was kept in the ACC once. And what happens is if you have a difficult crossing lesion, you just keep applying a constant pressure at that point, it somehow tracks inside. That's the specialty of Alpine tip. That is a difference. Basically, the stent is more or less similar to the Expedition, but the balloon and the delivery system seems to be slightly different in the Science Alpine. I've had difficulty sometimes, and you just maintain constant pressure there. You don't have to just do the pushing, trying too many gimmicks. And the other thing about first stent and the second stent not being delivered, which is what I was thinking in my case, was the guide wire bias. See, when the original stent went inside, the longer one went inside, the wire was in a different position of the vessel, wherein the stent went tracked inside. Once you deployed the first stent, the position inside moves. It could be closer to some kind of a calcific spicule or something. And it never goes
them, but I can't see them.
And the geometry of the vessel also alters.
Changes.
The stent alters the geometry. The proximal part of the stent actually maybe slightly overhanging or malopposed, and then you try to insert a new stent, it doesn't go. So sometimes, in fact, if you use a NC balloon for post dilatation also, as Dr. Prabhakar is saying, there's a guide wire bias, and that O balloon doesn't actually go. So you actually try to change the position of the guide wire, even change your view. If you're working in an epicranial view, you go to epicaudal or the ariocaudal, and then try to just give a small twist on that balloon and then see that Oxford that goes. So guide wire bias, change in the geometry, some amount of malposition at the proximal part of the stent in a calcified lesion.
Pull the wire a little, push the wire a little.
Yeah. So all these things, maybe take that Ox balloon back into the guiding and inflate in the guiding and shape that balloon. All those kind of tricks we have to do, but at the end of the day, we are getting more and more complex and challenging cases, and our patients want the procedures to be done immediately. And at times, you actually, in my case, I actually thought that it's a TIMI 3 flow, and I tried to explain to them, but they just did not agree.
Dr. Girish sir came. Now you see him. Now you don't. I think he's just in and out again.
Dr. Girish sir is back, sir.
Girish sir, you unmute yourself and talk, but only thing is you're upside down for all of us. I think you invert your mobile, I think we'll be okay. Yeah, now you're good.
So you have to unmute, sir. You're muted. Girish sir.
Oh, I'm so sorry. There is certain chance that I have to quickly run and switch over. But I think it's a great learning. We all know what we're doing. I think this debate about what worked, what did not work, and if I'm challenged with the same situation again, how I may do a few different things, that's what is going to help all our audience on the platform. I think great discussion.
Getting into trouble in the cath lab seems to be our habit, sir.
I think what is important for an interventional cardiologist is set a time limit for everything. If we keep trying the same thing, we're not going to get a different result. So we need to try different things. So set a timeline, 10 minutes, 15 minutes. If it doesn't work, my strategy is going to be plan B and plan C. And if not, eventually it's burr. Pull out a burr and just drill it down. You can solve everything. I feel when I see a long calcified lesion, just the 1.5 burr makes your life so simple, even before your first balloon dilatation. If you don't expect a severe slow flow, a lot of thrombus burden, I think there is nothing like rotablation.
Yeah, very true, sir. But I think Sami didn't have the rota at that time. He was very clear that he was constrained in time alone there, and I think that was very, very clear. I think Samir, probably you should get the Guide Plus.
Makes sense.
Yeah. Many of my colleagues suggested get the Guide Plus. That is much better than the Guidezilla.
No, you don't need the balloon support. It's so soft. You can straight away push it inside the vessel. It's really good.
But do you recommend, sir, pushing any guide extension catheter without the balloon in place distally or without the shaft of the balloon?
I have done it. I've got it about thrice, but I've got something there as far as the balloon goes. But this slides inside and never created a problem.
Yeah, some authorities say that don't inchworm, you just place the balloon distally and take the guide extension on the shaft of the balloon. That also works, but without a balloon just going over the wire, is it safe, sir?
Now this one goes inside, but that is the advantage of that. You don't need a balloon, and it is there. There are two ones with two varieties like I projected, and one of the smaller lumen, one of the slightly larger lumen where you can deliver all the gadgets if you want, and it's pretty effective. Every time I've actually had to shift from a Guidezilla.
So which one do you want us to keep in the shelf? Amongst the two, the
Guide Plus 2.
So Guide Plus is 1 and Guide Plus 2.
The Guide Plus 2 is the one that is coming now.
Okay.
Ravi sir is coming, or is he stuck somewhere?
No, sir, sir is coming, sir. He's trying to join, sir. Dr. Sanket, can you please try to connect with Dr. Hiramar, sir?
Swapnil, we were discussing a little bit about the cholesterol values of your particular
Yes,
case,
sir.
131.
Yes, sir.
So how soon do you check your lipids again?
So she is probably, usually I do check after 30 days, but in this case, as after discussion, I have made my mind to check it in the next visit. Probably she is due to come in 2 or 3 days to the clinic. So I'll definitely check and add ezetimibe.
And what's your experience with bempedoic acid? I'm just buying time for Dr. Sirish to join.
No, sir. I have not used bempedoic acid till now.
No,
Girish,
I
is
think
there
there is,
user?
yeah, there's definitely a scope. What I've realized is about 40 to 30 to 40% of the patients will not be able to up titrate statins to the maximum dose. There's a difference between maximum dose of statin, which is ideal, or maximum tolerable dose. 20 mg, most of them will tolerate. It's only about 10-15% who may not tolerate. 20 mg of rosuvastatin or a 40 mg of atorvastatin. In spite of that, I think 40-50% of the patients LDL is going to be more than 70. So if somebody who's got a multivessel disease, you want it, between 35 to 55. That's the target. And I tell them add ezetimibe with 40 atorvastatin or 20 rosuvastatin. It is not reaching there. Either PCSK9 inhibitor or what do you call bempedoic acid. Today, there are people who can just tolerate 10 milligrams of atorvastatin. So I've been, along with ezetimibe, I've been using bempedoic acid.
But actually, I'll beg to differ a little bit here. My usage is predominantly straight away start 40 milligrams of rosuvastatin. And what I do is check at the end of 1 month. And if they reach target, my target is 50 milligrams for a stable single vessel disease, multiple disease, 30 milligram. Actually, I'm part of the Lipidization of India guidelines. So we say 50 and 30 for polyvascular disease and high risk patients. So I target 50. And if they don't straight away start ezetimibe, I did an analysis of my own data, and 20% of my patients with ACS are on ezetimibe also. And most of them, unless they are going to be very thin built or less than about 60 kilos, I usually give them 40 milligrams of rosuvastatin.
No,
otherwise, it's only going to be rosuvastatin 20.
Do all of them tolerate without much problem?
Yes, sir. There's not much of a problem at all. Actually, it's more in our mind. What happens is the statin intolerance, the statin associated muscle effect usually happens within the first 3 months. Bilateral, symmetrical, and involving proximal muscles. Now, we don't attribute the rest of these symptoms to statins. So if you carefully do it, I think you can still manage it with these patients. Don't tell them anything. Just give them the statin. And when you start it during the index event, invariably they are fine.
I agree. And I think Google is their biggest problem.
Yes.
Yes, sir.
How frequently do you test the LFT, CPK, and hepatic profile, sir? How frequently?
LFT not required. CPK, if you want, at baseline, you can do. Next, CPK is only recommended if you have symptoms. Otherwise, you don't need routine monitoring at all.
But what are the one of my friends actually who had an angioplasty and he was on rosuvastatin and actually developed very severe myositis, had to be switched over to PCSK9. He was just not tolerating, although he had multiple other issues also. So I don't know, maybe hepatic profile, CPK, and these things, how frequently should we make it medico-legally also and for our patients?
No. It's guideline directed. Even as early as 2012 or 2013, ACC came up with a recommendation and said routine LFT is not required. And the CPK, MB or CPK levels are required only in case of symptoms, otherwise not required at all. This is medico-legally tenable, and because it is guideline directed. You don't have to routinely do it.
Okay, can I start?
Yes, sir. Please, sir.
All right. This is a guy who is in mid-60s. And as you can read, the patient has diabetes, hypertension, lots of alcohol, inferior MI, 2015 RCA was stented. Now he has a lesion in the proximal LAD for which he was getting angina. And I'll show you the angio, but you can see a very critical lesion at this particular point. I will show you on a fuller screen soon. So this was the ulcerated ugly lesion here. But when we were thinking of doing this, we had some issues about distality of the left main, ostial LAD, and maybe ostial circumflex. So we thought we'd probably do an FFR after stenting this particular portion. So the plan was to stent the ulcerated lesion, which was responsible for unstable angina first, and then do a stent towards LAD, FFR towards LAD if positive, a stent towards LAD, and then do an FFR towards OM, and if positive, put a stent here. So this was actually, plan was to do a culottes after FFR. So I'll show you some details. This was the right, which was done 5 years back, holding well, and no need to treat this. So we are back to our left system. You can see a very ulcerated lesion. This could have infarcted also, but patient was having severe unstable angina. So these are question mark, distality of left main, ostial LAD, ostial circumflex, and a lesion in the proximal OM. So we said we will do FFR to these lesions. This is what I generally do these days. Many times I'm with 7 French EBU because you can take 2 balloons, 2 stents at the same time, and sort of gives you multiple options to change your strategy. So we did the stent to the ulcerated proximal lesion, which was probably the culprit for unstable angina. And you can see we are actually measuring the length. This I do very often, like this same stent balloon is pulled back. It is at the back end of the deployed stent, and I'm trying to measure the ostium of left main through the deployed stent length. Here, both are very important. Normally, one site is important, but here you must get the ostium correct and you must get the stent into the deployed stent. So both are very, very important. And that's why perfect sizing is very crucial. And then we did FFR to LCX, which was 0.74. And so which meant that even LCX needed to be done. So we had to choose a strategy which is going to be good for the left main distality. So after the LAD stent, we did a FFR to LAD, and that was also positive. So both circumflex and LAD after putting this stent are showing positive response. So we are left with distality of left main, LAD proximal, and circumflex proximal going towards OIM. So this is the post-dilatation of the LAD stent. And then we have a stent from left main ostium to the deployed LAD stent. So you must get both ends fully covered by the stent. The best way to visualize the ostium, I feel, is not this one, but it's a LAO caudal view. And this is the caudal view you can see here. So it shows the ostium correct, and you can see the stent marker or balloon marker on the stent is a little bit in the aorta. So this, I think, is a correct position, and we are ready to deploy. This angle is LAO 30, cranial 30, and we double check in shallow RAO or AP with the cranial angulation. So once the stent is deployed, right now there is no wire in the circumflex, but you could see there is a significant pinching at the mouth, probably better seen in LAO view. So at this stage, you need to wire the circumflex. Before that, you must do a pot. Pot will actually allow you to pass your wire into the side branch, that is circumflex, more easily. And after pot, you can actually do a stent boost to make sure that the stent is well expanded. And then you can see the wire. Generally, I like to take a hydrophilic wire, and that's cross 100 is wire of my choice. So this wire is in LAD, and now we are trying to put a cross 100. And cross 100 actually is making good progress towards the OM branch, which is under consideration. So I always like to do sizing, and you can see 30 millimeter length. The distal end is going beyond the lesion. So probably something like 25 length is required. At this time, we post-dilate both the stents in the LAD and also the left main. Then we put a small balloon, maybe 1.5, towards the circumflex. We deployed left main stent. We inflate this, open up the struts, and now we are working on LCX. So we could have done a tap as here, but we thought whenever you're dealing with an ostial lesion, better to bring the stent back more towards left main and do a culotte. So we opted for culottes here. And you can see there is a stent beginning the ostium of the left main. We got the stent in position. Part of the stent is in the left main. And after this is the deployment, balloon is up. And when you take a stent boost, you can see the gap between the two stents. This inside one is going towards circumflex. The outside one is towards LAD. There is a clear gap here, so we do a high pressure inflation, and you can see the gap vanishes on stent boost. Stent boost is a very easy and effective way to decide if you got your stent fully expanded or it is not expanded. And we use it very often. It gives a lot of radiation, but I think it's very, very useful and quick too. Then after doing that, we are actually, after pot, we are crossing towards LAD. Then we are post-dilating the stent at high pressure. Then small balloon towards LAD to dilate the stent struts. And then you have two balloons, one towards LAD, one towards circumflex. Stents need some kind of finish. Stent boost gives you all these important information. So high pressure on both. When we go high pressure, we take both to about 10 and keep one at 10, like LAD would be kept at 10. This balloon would go high pressure, probably more. It would need some adjustment inside. And this is some of our final result. So you have two stents in LAD and left main, and one stent as culottes on the side branch. Of course, you do a case and simultaneous inflation, etc. You can see in areocaudal view the flow to circumflex and the big OM branch are perfect. Flows to from left main to LAD are also very, very. And this is how the stent position is. First stent in the ulcerated proximal LAD lesion. Second stent from ostium of left main to the stent deployed. And third stent from OM back to left main. And a final case and high pressure inflation in all the areas. And this is the final picture. So I would probably feel that somebody might say, why did you do culottes and not tap? Or tap would have brought the stent here. I would probably feel that whenever there is an ostial circumflex lesion, the stent should be on either side of the lesion. And that's why I generally like culottes, especially when we are doing a proximal bifurcation like this. Sorry, I think this is the last picture. This is the final position of the stents. Stent 1, yellow, stent 2, red, and stent 3 in blue. And this is a culottes. So you end up with final kiss, and then again you come in with a pot like this and dilate the left main. So whenever you have two stents like this in the left main, you must dilate the left main with an NC balloon at a very high pressure. So I will stop here. Any comments on, or anybody would have done differently?
I think excellent thought process, sir. The first one was to make a decision whether the left main needs to be treated or not. I think it was very wise of senior statesmen to know, if I just treat the LAD and leave the rest of it on medical management, if it is not, FFR is not significant, that would have been the best for the patient. And second, once you decide to treat a left main bifurcation, how do you make a choice, sir? Culotte, decay crush, or a provisional? A case like this, why did you choose on culotte but not decay or a provisional?
Somehow decay has too many steps, and culotte probably has fewer steps. Probably end up quicker and probably with lesser contrast.
But do you also not take out the wire and recross? At times, that's the biggest challenge with culotte, that you need to take out the wire from both the vessels.
Yeah, I mean, you could do that. I mean, I don't see. I mean, culottes is probably my most favorite technique, because you don't miss any lesion, not even a millimeter square, when you do culottes, and the metal coverage is brilliant with culottes.
I tend to agree, especially for in a left main. I think that metal burden really doesn't matter in a 4.5 or a 5 mm vessel. And the second question that I had, sir, the second stent that you implant in culotte, is that not to be the longest stent that would come out of the left main rather than the first stent?
I mean, that is what generally we tend to do, but no harm doing this way, that the first stent is actually coming at the left main. You may be finding it a little bit difficult to take the second stent if the stent is at the ostium.
So you could,
but you can always align it with the, I mean, you have wires inside, you can put a balloon, lift this guide catheter, and
Incubate it, yeah.
align it with the left main.
Excellent, sir. Thank you.
No, I think you made it look very simple. The way you did it sound like it just went off like a harmony. You just had a explanation for everything. Now the question
No.
that I wanted to ask was what Dr. Girish asked the last
I
question.
presented it fast. Okay, go ahead.
My understanding of QLOT was the second stint comes out and that's how it was. I think this is a different way of doing the QLOT. But I think any normal person wouldn't have opted for a QLOT in that. Probably probably just go ahead, use the second stent and then come up to the ostium, use a crush it there at the use a T stent, crush it there at that point, and then get out. That's but I think it makes a lot of sense, which what Girish said, at a 4.5 or a 5 millimeter vessel, having more metal really doesn't matter. I think that logic, like if it was some other bifurcation, what would be your thought process, sir?
Sorry, say it again.
If it was bifurcation was not a left main. Let's say it was one of the major diagonals, big diagonal, more or less similar situation, but it's not at the left main. Would you still do QLOT?
No. Diagonal LAD, I generally like to do tap.
So this is only because it's the left main can take a large amount of stent. I think that's what Dr. Girish was also telling. I think that makes a big difference. I think we should get the message very clear here that because it's a left main, you can do the QLOT more comfortably and get away with it. But I think the procedure was, you executed it so perfectly. I think there's not much to say there.
Thank you.
So I have a very basic question.
Of the balloon while doing kissing.
What is the number?
So while doing the final kissing.
Sorry, can you ask it? Huh?
What did till what pressures did you went for final kissing?
No, typically these are 2 NC balloons. In this case, probably I will take 3.5 in LAD and a 3.0 in circumflex. So I take both to about 10, stop at 10, go high on LAD to maybe 25 or 30, and then come down on LAD to 10, and then go high on the circumflex, and then both are down to 10. Then I would probably go to 12, probably go to 14 together. And if you are 14 on both, I think you probably have an adequate dilatation. You have done one by one, very high pressures like 30, and then simultaneously about 14, 15, 16.
And did the pressure damped while you hooked the guide catheter at the left main ostium?
No. I think when you pull out the balloon after deploying the stent, I would probably leave the balloon inside, adjust the guide catheter so that it's probably very parallel to the deployed stent in the left main. If you have a guide catheter which is looking up like this, not a good idea. The guide catheter should look horizontal into the left main stent, and then you will have no pressure drop. If it is touching the roof of left main, you would get a damping of pressures.
So I have a very basic question. When you were deploying the left main to LED stent, there was no wire in the circumflex. So is it your routine practice or your experience, or what do you suggest to people like us?
No, I would probably feel that the circumflex mouth was not critically diseased. Probably the FFR came positive because of this distal lesion, which is away from the ostium. So if ostium is quite normal, I avoid putting wire on the side, because you deploy this stent left main to LAD, do a pot. A pot creates an angle for you. Fully dilated, sort of a wedge, and then the diameter of the LAD. So at this stage, you can enter the circumflex very well. So I would probably make a choice based on the criticality of the ostial circumflex lesion, whether to put a wire there or no. Putting wire is anyway you have to rewire again. So it's not a huge advantage. So I skip it many times.
But whatever the conventional thought is that even if everything is fine and still a wire probably, I mean, with experience like you, obviously, it's not a problem. But for people like us, at times you can have an acute occlusion, or maybe that serves as a guide map also. And especially if you're dealing with ACS, probably the plaque shift and other can be catastrophic. So would you still recommend us not to wire it, sir, or depending upon the clinical scenario and other aspects?
Yeah, I think make a choice based on what you're dealing with. But I guess, I mean, it's a waste of effort if there is no lesion at the mouth of side branch. Because after you put a stent, the side branch will still be flowing if there is no lesion, no critical lesion. And that allows you enough margin to get your wire in the side branch. I mean, putting wire in the side branch is a rule. I mean, standard practice. Not putting is a deviation from the standard practice. But I guess there was no lesion at the mouth of circumflex, so it would never close. And that's why we took a chance. Dr. Prabhakar, you're smiling, so you have some other comment?
No, sir. Actually, I think if you had a lesion, you would have probably pre-dilated a little bit at the ostium also. And that looks fairly good. And
no, you know, for culottes, I don't pre-dilate. I mean, I would dilate the side branch. Here it is circumflex OM, only after you wire. So if it is, I mean, you put a main branch stent, do pot, wire the side branch, dilate, get your stent in, and do a deployment, and then you do a kiss. So I would probably feel the no lesion at the mouth was probably the reason why we didn't wire. But if you're wiring as a habit or as a routine, I think it's a safer strategy.
So what I would have done is what Samir said. I would have kept a wire there, because anyhow we have to do the angioplasty to that, because you showed the FFR was significant there. I would have kept a wire just for a guide, just in case, and probably used it as a guide. Nothing happened here. You're an experienced operator. You can get it. Sometimes even if those wires, they get very tightly pinched. Once you do the pot, like you say, the key is the pot. Once you do the pot, you will be able to get inside the side branch most of the time.
And so my second question is, what are your practical tips regarding rewiring through the proximal strut or the distal strut, or does it actually matter in these scenarios, or it's more of a theoretical discussion and practically on table? What your personal experience? I mean, you're such an expert.
I have told my ward boys to clap when I access the side branch. So whether it's distal, proximal, I don't care much. But generally, I like to go distally. Like I would probably, the wire which is going to a side branch, I would bring it towards LAD, come back, and while coming back, keep looking down, keep looking towards circumflex, and probably pick up the first opportunity where the wire is getting into circumflex. This is more or less what you people call as distal wiring, correct?
Yeah, so this is for provisional cases. If you have a provisional approach, or this is also the scenario for elective double stent strategy, or you don't care much about whether it is a proximal strut or a distal strut in the elective double stent strategies. So I think it's more of a theoretical. I don't know how people are sure.
Absolutely. I entirely agree. People show it on OCTs. People show it that the distal aperture is bigger, wider, easier to get in, and things like that. And they show that, yes, I'm going to the distal one. Maybe they're champion and probably easy. But I would probably feel that I have never sort of like, if I get into the side branch, I would just not worry to check whether it's proximal or distal.
So does it matter in culotte, sir?
It matters.
Distal is better.
Distal is better, yes.
Yeah, I think, the safest approach is that anything non-proximal is good. The reason is the first crossover needs to bring the stent from the distal to the proximal part when it crushes. Otherwise, you would have certain area of the ostia which is not covered by the stent and not covered by the drug. That's the concern. If you just cross the very first strut, the first cell that you get, you may crush the balloon stent without the entire vessel ostia being covered by the metal for the mechanical simultaneous kissing or even drug elution.
So you are probably trying to say that distal cross is better. Most of the time, we like to cross distal.
Absolutely.
But I would probably accept whatever has crossed and the balloon is going easily, I would probably accept and not waste time.
I agree, sir. I think we should accept it non-proximal, take a balloon, do a balloon, stent boost. You would definitely know that the balloon has gone inside the stent. The whole idea is it should be inside of the stent. Sometime when you have done a decay crush or the wire has gone between the stent and the vessel wall. If you just allow the wire to go and then once you open your balloon, you have completely two layers of the stent are on the opposite side. I think before you dilate the balloon across the distal left main, please do one stent boost to know that you're inside. The balloon is covered 360 degree by the stent. Second, the easiest way to access distal cell is first go into the distal LED, come back, and the first cell you can go into the circumflex, try that. Always enter the LED, go distal, keep coming back and trying. Not directly from proximal trying to enter the circumflex.
Seriously,
what about mini crush elective double stent strategy? Some people say that in a elective double stent strategy, mini crush do a proximal cross rather than a distal cross.
Let me just tell you, I think there you're depending on chance quite a lot. The reason is you are prolapsing the side branch stent least possible, unlike decay crush or a culotte. You need to be very, very precise. And once you have opened the side branch stent, most often you know that stent is tilted like this. The distal carina is never completely opposed. It can be unopposed, especially when you're going to take out the balloon from the side branch, the stent balloon, and deflate the main vessel stent without optimizing the side branch ostia. You are going to crush the lower part of the stent from the side branch ostia, and you will have a potential space between the distal carina and the stent strut. Of late, what I have done where there's a urgency where you have to do two stents simultaneously, what we call mini crush, I take out the side branch stent balloon and use an NC balloon to just go and open it up fully and plaster that into probably 0.25 millimeter larger balloon, NC balloon, and open it. The stent does not get moved. The main vessel stent will remain where it is. Don't be worried about it. Use an NC balloon, fully oppose the side branch ostia, then only crush. Otherwise, it'll take almost 2 or 3 times the duration to recross into the side branch compared to either culotte or decay crush.
So my question was, in such a scenario, the recross has to be proximal or distal?
No, here again, it has to be proximal, not distal. Why? I told you, the distal stent is crushed upward, leaving a potential space between the stent and the distal carinal wall. So if you have done a very good ostial complete coverage, then you can go in. But you need to go to the final kissing is always going to be the proximal cell. The first access is going to be the distal. If you're going to take a stent through the main vessel stent into the side branch, you have to enter distal cell. But if you're doing the final kiss, it has to be the proximal cell because both sides metals are present.
So the bottom line is, in a provisional, distal is better, but in an elective drug, elective double stent, probably a proximal is better.
No, you need to get this point of mind. You have got a main vessel stent and then you're accessing the side branch without a stent. At that step, you have to access the distal cell.
Absolutely.
Okay. Once you have implanted the distal, both the stents, now you're going to recross. Okay. At that time, you don't go to the distal cell, go to the non-distal or the proximal for the final kiss.
And what about EDS, elective double stent mini crush?
Sorry?
You deploy the first stent in the side branch, and then you crush it with the main branch stent. So now you do the recross again proximally.
That is what I am saying. That is the most dangerous among the bifurcation stenting, because you have a lot of stent which is not completely opposed to the ostia of the side branch, and it is not even completely opened because your stent balloon will always look towards the left main. Imagine you are doing an LED diagonal bifurcation like that. It's always looking up and it is never opposing the lower part of the stent to the distal carina. Only the proximal part of the carina is taken care. In that, you better go at a high pressure and make sure entire carina is open. And then you deploy the main vessel, then cross proximally before you do the kiss, not distally.
Okay. Thank you, sir. Thank you.
So in general, the carina has to have a metal, right? So for that, all these steps are very important. All right, Dr. Onkar, I think looks like we are done for today.
Yes, sir. Look, yes, sir. Yes, sir. So we have more than 300 participants who are on live listening this program, excluding those who are logged on YouTube. So we have not count on YouTube, but for this platform, there are more than 300 interventional cardiologists who are watching this program live, sir.
Number is less compared to what we used to have. We used to have 700, 800.
700. Sir, today it seems there are multiple programs ongoing, but few are on the YouTube as well, sir. YouTube is also, we have.
No, Onkar, you took an off for a few months. That's why the number is less.
So we'll make sure, sir. Next time we will have that, sir. But this is our 43rd program, sir. 43rd program. So it's now we have last more than 2 years. We are doing this, sir. It's a 43rd edition which we concluded today, sir.
So half century just around the corner.
Yeah, around the corner. So that's what I. So
in fact, I have presented 3 times in this program. This is my 3rd.
3 times?
Yes, sir.
3 times?
I have done program with you last time, which was a bifurcation, a mini crush. I presented L6OM few months back.
I think it's a great program. You know, you have the great wisdom of somebody who's been from the inception to the evolution, and there are a lot of others who have come in between, people like Dr. Prabhakar and very little like me, who bring their little experience and try to counter with whatever is happening. And you're the next.
Sir.
Let's understand that little experience.
Yeah, that is little for him, sir.
Sorry. No, it's a wonderful program. I always look forward.
All right. I think overall Emcure has done a great job. I think for almost 2 years and more, I think we are coming back again and again. So all the participants, like Swapnil tells me, this is the 2nd or 3rd time he is presenting. So very good, strong enthusiasm, and I'm sure it will take you a long way in your life. All our best wishes.
Thank you. Thank you, sir.
Thank you.
Good night,
We always feel your keen interest and your enthusiasm are making this program success, along with all our moderators who have been always with us, supporting, joining this program and discussing and bringing the pulse of wisdom that really made this program success, sir. So with this note, sir, we will stop here at this moment and we'll join once again in the next month with 2 or 3 interesting cases and a lot of discussions, sir. Till then, I wish good night and have a nice time ahead, sir. Thank you.
So special thanks to Prabhakar sir and Girish sir. Both are very busy, and they have put their time and they have attended today's program. So once again, thanks to Prabhakar sir and Girish sir. Also thanks to Dr. Sapni and as well as Dr. Samir Koba sir. Thank you so much for your time. And also Girish sir, thank you sir. Thank you so much for all your guidance and support. Thank you.
Thank you. Thank you, sir. To learn from the master. Thank you so much.